Hello, and welcome to the Royal College of Pathologists Guideline Implementation Webinar Series. My name is Peter Johnston, and I'm the Vice President of the Royal College of Pathologists. I'm delighted to be hosting the webinar today, where we have some leading experts and authors around the tissue pathways for cardiovascular pathology guidelines. The point of the presentation is to clarify some aspects of the guideline that members may find difficult or tricky and help with practical tips and some clinical scenarios that are relevant to our practice. They'll also be here to answer your questions. I'm pleased to introduce to you today's speakers and authors of the tissue pathways for cardiovascular pathology guidelines. The first is Dr. Jose Coelho Lima, who will be presenting the presentation, Dr. Kathryn Griffin, and Dr. Lauren Dessart. Before we start, I'd just like to remind you that the presentation will last approximately 15 minutes, leaving the rest for questions and answers. All the participants will be muted apart from the presenter. And so if you want to ask a question, please do so using the Q&A function that you'll find on the bottom bar of the Zoom screen. What we'll try to do then is to pull the questions together around themes and address them as we go. So without any further ado, I would like to start this off by welcoming our speaker. Jose, over to you. Thank you very much.
Good afternoon, everyone. Thank you, Prof. Johnston, for the kind introduction, and would like to thank the college as well for the opportunity to discuss the guidelines with the wider audience. I'm just going to now share my screen with the presentation. So this is the list of the authors for the guideline, and we would also like to thank Dr. Martin Goddard for overseeing the writing of the updated manuscript and providing senior input and support to us all. First of all, we would like also to pay tribute to the late Professor Kim Survana, who sadly left us earlier this year, who was the leading author for this guideline. I'm sure that you will join me in acknowledging that his passion and dedication to cardiac and autopsy pathology greatly influenced and inspired us all, and that his work will live on. So the aim of the Tissue Pathway Guideline series from the college is to provide pathologists with guidance on how to deal with routine surgical specimens in a consistent manner and to a high standard. But of course, these guidelines cannot cover every single specific circumstance or specimen. So variation from practice from the recommendations may be required. So how was this guideline developed? The last guideline was published in 2018, and last year the college decided that this should be updated. So in order to do that, we contacted or consulted the main stakeholders, being the UKCPN, the UK Cardiac Pathology Network, and the National Amyloidosis Center. And we performed a literature search on databases such as PubMed and Bayes, comprising literature published from 2018, the year of the previous guideline being published, and 2023, using these key terms. And we also used the previous guideline as a base for the scope of practice. To be very honest, not a great deal has changed. But we performed some updates in terms of the style, in terms of providing more images, and of course updating the some references. We also reviewed guidance from other professional organizations that have been published, such as the Association for European Cardiovascular Pathology, and we reached consensus for some of the recommendations by expert review. Then a draft of the guidelines was reviewed by the college team and a lay advisory group. And this draft was then open for public consultation with the wider membership of the college in May and June this year. Also, we utilized for a lot of the background information in this guideline, we used established literature in cardiac and autopsy pathology present in these publications, in these books by Prof. Survana and Prof. Mary Shepard. So we are going to go through the main sections of the guideline to try and highlight the key take-home messages or the key tips that we would like you to have. And then at the end, as Prof. Johnston said, there will be a question and answer session where you will be able to ask everyone, all the authors, questions if you need further clarification. So the first section of the guidelines dealt with endomyocardial biopsies or diagnostic endomyocardial biopsies. So we recommend at least 4 or 5 biopsy fragments to be taken or to be submitted. These fragments should be fixed in formalin, but additional pieces should be considered or could be considered for fixation in glutaraldehyde or for freezing if further ancillary techniques such as immunofluorescence or electron microscopy are needed, or molecular biology testing, for example. And at least 3 to 5 levels of each fragment should be stained with H&E. Additional suggested stains such as EVG, Congo Red, Pearls, or PAS-D can be considered depending on the appearances on light microscopy and the clinical history. In terms of ancillary techniques, immunohistochemistry can be performed in cases of suspected Duchenne and Becker muscular dystrophies, for example. Immunohistochemistry for dystrophin may be helpful, or for amyloid subtyping if there is clinical history or depending on the light microscopy appearances. So immunohistochemistry for amyloid A and P, for example. Electron microscopy may be incredibly useful for the diagnosis of certain entities, including some types of cardiomyopathies, lysosomal storage diseases, or mitochondrial disorders. So, for example, in the case of Desmin cardiomyopathy, electron microscopy may show intracytoplasmic aggregates. In terms of Fabry's disease, the myelin-like figures may be seen on electron microscopy, or alterations in the number or structure of mitochondria as well can be seen in mitochondrial disorders. And the diagnostic report for diagnostic endomyocardial biopsies should provide a systematic description of these different compartments of the specimen, including endocardium, myocyte, interstitium, and blood vessels, noting the main alterations or if there are any alterations in any of those compartments. So, for example, if there is elastosis or fibroelastosis of the endocardium, is there any hypertrophy, necrosis, vacuolation of the myocytes, for example, that could point towards a specific entity? Is there interstitial fibrosis, interstitial inflammation? In terms of the vessels, are there any microthrombi? Are there dysplastic features of those vessels? And so on. Endomyocardial biopsies can also be received in the lab in the context of transplant rejection surveillance. And for these, we recommend a minimum of 3 pieces of evaluable myocardium for evaluation of acute cellular rejection post-transplant. What do we mean by evaluable myocardium? Is that each piece should contain at least 50% of myocardium, discarding or not considering, for example, areas of fibrosis, fat, previous biopsy site changes that may be present in those fragments. A minimum of 3 levels through the block with at least 3 sections at each level is the recommendation. And the standard of practice is that these pieces should be stained with H&E. There is no need for routine specialist stains to be performed. And the ISHLT has changed the guidelines or their guidance for performance of immunohistochemistry for surveillance of antibody-mediated rejection to include C4D and CD68 on a minimum of 2 biopsies during the first 2 months post-transplantation, and then follow a similar schedule to the center serological testing for donor-specific antibodies thereafter. CD4 positive immunohistochemistry is considered when there is more than 50% staining of capillaries, and a positive CD68 requires intravascular macrophages to be present in more than 10% of the capillaries. The diagnostic report for these specimens should state the adequacy of the specimen. It should grade the presence of ACR and or AMR according to the 2004 issued criteria, which is summarized in this paper here, and the presence of broader pathology. So is there any evidence of Quilty lesion or peritransplant injury or previous biopsy site? For example, for Quilty lesion confirmation, one might consider the performing immunohistochemistry, for example, to identify subsets of B lymphocytes and so on. The next section of the guidelines dealt with cardiac valve specimens, which are relatively common. So for those specimens, one should note the key macroscopic features, so provide measurements of the leaflet or leaflets that are submitted, and also describe carefully the external appearances. So is there any, for example, fusion of leaflets, prominent calcification, or the presence of vegetations? Are there any changes consistent with carcinoid heart disease, for example? One should also consider the presence of dual pathology, so careful examination is paramount. And in terms of blocking and sectioning and blocking, the recommendation is that a perpendicular section in relation to the line of closure should be taken, and that at least in a minimum of one block per leaflet should be examined. Routine staining with H&E is recommended, and further special stains may be considered depending on the clinical presentation, depending on the macroscopic findings or light microscopy appearances. And these include, for example, stains for connective tissue, such as and fungi such as ABDPAS, or for bacteria if there is any presence of vegetation such as ground stain, Congo red for amyloid, alizarin red, or von Cossa for calcium. And anyway, but this is not an exhaustive list. The next section is regarding the dealing with non-malignant and malignant cardiac masses. So for those types of samples, accurate macroscopic description with particular attention to the presence of any stalks is very important. And if a stalk is present, that should be inked. So one should describe the measurements, the external appearances of that mass, as well as the appearances of the cut surface. In terms of block taking, the entire base or stalk of the mass, if present, should be inked and sampled to confirm excision of the mass, as well as the entirety of the mass if that mass is small, less than 3 centimeters, or if it is a larger mass, one should use judicious block taking. Approximately 1 block per centimeter should suffice. Of course, sampling areas of interest in terms of the tumor. The sections are stained with H&E, EVG, and ABDPAS in the first instance, and relevant immunohistochemical panels should be considered or selected according to the histopathologic appearances and the clinical information to confirm a specific diagnosis. The diagnostic reports should state the name of the preferred entity and the excision status if accessible. And remember that metastases are the most common tumors in the heart, and cardiac myxoma and papillary fibroelastoma are the commonest primary tumors. If in doubt, also consider referral to a specialist cardiac or soft tissue pathologist for second opinion. Then the next section of the guidelines was about aortas and other vessels. So aortas are usually received as a part of thoracic aneurysm repairs, and one should describe first the macroscopic appearances. So is there any intimal defect? Is there any dissection plane, any thrombi, any features that could indicate the presence of aortitis or vasculitis, for example, thickening of the walls? And then 6 pieces should be, or 6 sections should be submitted in 2 separate cassettes for an initial screening. But if there is known or suspected vasculitis, up to 12 blocks or 1 per centimeter can be taken. These sections should be embedded on end and be stained with H&E with or without additional special stains for connective tissue or for mucopolysaccharides, for example, and calcium. Microscopically, one should provide a systematic description of the different layers of the blood vessel wall, the endothelium, the intima media, and adventitia, noting main pathologic features in any of those. And one should follow international consensus statement guidelines, which are these ones here from the AECVP in terms of inflammatory aortic diseases and non-inflammatory or degenerative vascular diseases. So in terms of atherosclerosis, the American Heart Association hysteric classification is the one that should be used to describe the severity and the main pathologic features associated with atherosclerotic disease. In terms of medial degeneration, this is the grading criteria or the grading scheme that is recommended by the AECVP. So it is a grading scheme that amalgamates or that incorporates different parameters, including the architecture of the vessel, the presence or the loss really of smooth muscle cell nuclei, the presence and the extent of mucoid extracellular matrix accumulation, Lima, and the presence of laminar medial collapse. The grading should be based on the worst area, and depending on the findings, think about genetic diseases. So if there is abundant mucoid extracellular matrix accumulation, one might think about diseases such as Marfan syndrome, for example, and that should prompt communication with the clinicians if this is not suspected and for consideration of genetic tests. And in terms of aortitis and vasculitis, therefore inflammatory aortic disease, one should integrate autoimmune serology and clinical information if available, and describe the severity, the extent, and the type of inflammatory infiltrate that is present in the vessel wall. The next session is about temporal artery specimens for the diagnosis of giant cell arteritis. We highlight in the guidelines that there is a lack of agreement regarding diagnostic features and classification of inflammation in this context. But one needs to include or to consider the clinical information that is provided. So what is the clinical presentation? Has the patient been started already with steroid for suspected GCA? Because that, of course, can have an impact on what you're going to see down the microscope. In terms of how to approach the specimen, one should measure the length and diameter of the specimen and then perform transverse sections 3 to 5 millimeters long and embed on end or on edge. The entire tissues should be submitted because, as you know, this can be a focal or very patchy process. And the specimen should be stained with H&E with or without EVG, but we find EVG extremely helpful to highlight the general structure of the vessel wall and especially the internal elastic lamina. As I said, the disease is patchy, so at least 3 levels should be considered, but more levels may be needed if one is not satisfied that in initial levels that sample is indeed negative for GCA. And what are the key features that should be described? So the location and the extent of inflammatory cells and the presence or not of granulomatous inflammation, the presence of intimal hyperplasia, fibrosis, and degree of luminal occlusion, as well as whether the tunica media is intact or disrupted, one should be careful because there may be some overlap between with age-related and atherosclerotic changes. And timely communication with the clinicians is essential if indeed there are diagnostic features of GCA. Moving on, this is another type of sample that can be received, the PTE, so pulmonary thromboendarterectomy specimens. It usually consists of irregular vascular casts, and one should record three-dimensional measurements and note the presence of any thrombi or masses. Select blocks that include cross-sections of the different parts of the vascular cast, and embed multiple fragments in one block, preferably on edge, and these should be stained with H&E and EVG. Immunohistochemistry may be needed if there is any suspicion or appearances indicating the presence of a thrombus. And then finally, the guideline also incorporates guidance on the examination of cardiac dissection for explants and autopsy samples. So for the explants, usually those consist of atrial cuffs and ventricular chambers. The examination should consider the performance of photography to document the case. The specimen should be weighed. Examination of catheters from any devices, pacemakers, ventricular assist devices should be also performed. And thorough examination of the coronary arteries, the valves, and the myocardium, assessing for the wall thickness, for symmetry, for the presence of focal lesions or mural thrombi is also recommended. We also recommend that the heart should be sectioned using the axial method, performing complete transverse lysis sections of the ventricles at 1 centimeter interval from apex to the mid-ventricular level. And at least 5 representative blocks of ventricular walls and interventricular septum should be included, routinely stained with H&E and EVG, and consider additional immunohistochemical stains if needed. For the autopsy, it's a similar approach, but of course that in the autopsy setting, one should consider the medical legal implications of examining their heart. And you should also consider referral to the UKCPN or specialist cardiac pathologists in specific circumstances, depending on the case complexity and the experience of the pathologist. The guideline includes very nice pictures and specific guidance on how to examine as well each case. And finally, this is the final section of the guideline, which is how to tackle coronary endarterectomy specimens, which can be received, for example, in the context of primary angioplasty. So sometimes the clinicians will remove the core or some parts of complicated atherosclerotic plaques. This is still an area that is evolving and evidence is sparse, but we recommend that one should provide a macroscopic description of the specimen, process the entirety of the specimen, stain with H&E and EVG at least one level, and use the STARI classification or American Heart Association classification to classify and grade the severity of atherosclerosis. And finally, this is the criteria for audit as per the RCPath KPI, is that histopathology cases that are reported, confirmed, and authorized within 7 and 10 calendar days of the procedure, 80% should be within 7 days and 90% should be within 10 days as per standard. So I would like to thank you very much for your attention, and we are now going to be here to listen to your questions.
Thank you very much, Josie. That was a very interesting and comprehensive trawl through that guideline. A number of things come up to ask questions about, and I guess the first thing is round about practicality of reporting things within schedule. And linked to that, there's a question in already about workload in departments and how that affects what we should be doing. So I'll go to the specific question first of all, which is around microbiology and echo being of better predictive value than gram stain and microscopy. The question, which I suspect is deliberately provocative, is saying, why is the college still suggesting that we do additional work when we know that the other methods provide better answers? And it's a lot of work for us to do that.
Yes, that's a very, very good question. And I think indeed we had a similar question when we put the draft for public consultation. And the reason why we think it is important to still, examine those specimens macroscopically and microscopically is because, as I said, sometimes you can have dual pathology, or you might have some findings that might be missed, for example, by echo or clinically, or that were not suspected before. So examining those specimens macroscopically and microscopically could add some additional valuable information in some cases. Kathryn, would you like to?
Yeah, I think it is a really valuable question, and I think there are probably several points within the guideline where similar questions could be asked about, whether all of these samples are of high clinical value. I think that there's a tension there within the guideline. Is that the guideline's job to decide which samples are valuable or not, or is it to say, if you get these samples, this is how to deal with them? And I think we deliberately, as an author group, tried to say our job is to say how to deal with these samples rather than to discuss the value. And I've just looked at that study that was mentioned in the question. Actually, it looks like a very good study, a very good audit that was re-audited, and it sounds like they had a very good communication with their surgeons, explained what the histology could and couldn't add to the microbiology, and they've decided as a kind of an MDT team what the value of those samples are. And I think that's great if that can happen in your institute, but not all of us are necessarily working in those institutes. Not all of us have access to all of the clinical investigations or necessarily the microbiology. So I think for us it was about, if we get those samples, how do we best handle them? So but no, I think you're absolutely right, you can still miss things, and also microbiology and echo, yes, that they're the ideal investigations. But great question, I think.
Thanks very much. Lauren, do you have anything to add to that? No. Okay, thanks. Just while we're waiting for people to put in some more questions, because we've only had one so far, one of the things that I find interesting is the relationship around about, or the diagnostic criteria around giant cell arteritis. And one of the things you said in the guidelines and in the presentation was there are issues around overlap and where atherosclerosis and aging actually can look the same. And I find the textbooks on this subject are rather misleading, and some of them have different stories. And so I would appreciate some clarification around what those, where those overlaps truly are and where we can ignore them. Who wants to take that one? Kathryn?
Yeah, I can take that one. I think that's a great question. And again, this was something that we came up with again and again when we were having our author discussions, and particularly around GCA, actually, where the diagnostic criteria are really quite unclear, and the kind of interpretation of those findings is also really unclear. And if you look at the literature, there is quite a big split between how the UK and Europe are interpreting some of those findings and attributing some of the kind of inflammatory patterns to disease, and how maybe the US pathologists are interpreting those same findings. So, for example, if you look at the European literature, there's a lot of talk about these 4 different patterns of inflammation. The US don't really recognise an adventitial only pattern of GCA, for example. So there is a lot of controversy. There's a lot of research that needs to be done, which is why we probably all need to talk the same language and we all need to be reporting the same findings so that we can actually do the research, because you can't look back at these reports unless we're all at least reporting these findings. I think the question about GCA and age-related changes, I think intimal thickening is often given as a feature of GCA that's very non-specific and is often seen in aging. Elastin tissue development within the intima, so intimal elastosis, again, a very non-specific finding, can be seen in both aging, atherosclerosis, and also with hypertension. So they're the kind of features, I think, where there is an awful lot of overlap. And again, some of the primary literature that we referenced in the guideline, because we can't include it all in the guideline, but some of the primary literature that we referenced talked about how confusing people find these terms, and especially things like healed arteritis. What does that really mean? So we have done quite a lot of work in that section that's been expanded quite a lot to just try and say, you know, this is a really difficult area. It's very unclear. More research probably needs to be done, but therefore we probably do need to be reporting these findings so that we can do the research. But again, not the purpose of the guideline, and I'm not sure if I've helped, Peter, but yeah, it's difficult.
The help is really just in what you've said is helpful, but it's also useful that you find it difficult, which is reassuring from my point of view, at least. I have to poke the audience, please, because you haven't really done very well with the questions so far, and we have at our disposal 3 people who really know what they're talking about, and it would be really nice if you would ask them some questions. So while you're doing that, I've got a simple one that I think you might like to answer. You mentioned the use of CD68 and CD4 in the assessment of a variety of things. I can't remember exactly the context. I think it was in transplantation, Josie. I just wonder why you use CD68, or is that interchangeable, for example, with CD163, which I think is often a tidier antibody to use and doesn't leave the problem of making sure you've got the PGM1 antibody or the other one which cross-reacts with neutrophils. So I just wonder why the choice of 68 and whether 163 would be just as good. Josie, go on, or somebody.
Sorry, I was going to ask Lauren, would you like to take
this? Yeah, I'll jump in here if that's all right, Jose. Hi, so yes, so I guess CD68 isn't the only macrophage marker that we have, but it is the one that is used in our sort of international guidelines. So for that reason, we just use that one, and we recommend that if you're assessing it specifically for transplant in your endomyocardial biopsies, you stick with the antibody that everyone uses just for standardization.
Okay, thank you for that. So another question is in. It's accepting about comments around hidden diagnoses, and should we be working on algorithms for the surgeons when they send cases to us to stop us having to deal with samples of aortas that have been removed? So can we create an algorithm where we can have a shared approach to these cases, never mind the pathology, but the case themselves? So thinking about it more broadly, do we think there is a place for that?
Yeah, again, I'll probably take this one, given that it's aortas, which is one of my things. So again, Hannah, I think this is a really good question. I think it's a really good conversation to be having with your surgeons and with your clinicians. I think it's difficult because I think intrinsically we're biased, aren't we, by those cases. Those things that we picked up that we weren't expecting, or where the clinicians didn't tell us that piece of information. You pick something up and you think, oh, I'm so glad I took that section, or I'm so glad I put that bit in a pot. And so we are intrinsically biased. And also I think as a kind of as an academic and as a researcher, I think that the only way that we're going to be able to enhance our diagnosis and our predictive scoring systems and things like that is by knowing more about how the histopathology links to the molecular, for example. So if anything, I think we should be doing more histopathology and just scoring it better and kind of understanding those changes better so that we can then link them with the new information that's coming through. But I am well aware that that is not practical or pragmatic given the kind of the times that we are all living in. So yeah, I think having those conversations with your surgeons, you know, how worried are they about a potential aortopathy? How young is this patient? What are their risk factors? What is the family history? And I think having those conversations in a truly MDT approach, I think is really valuable. You know, we do it for cancer. We're not very good at doing it for cardiovascular disease, and I think we need to get better at it. And that's because the molecular is improving, but it's also because the imaging is improving and the clinical diagnosis improving. So we can do more for these patients often than we ever could before as well.
Yeah, thanks very much for that. On a similar sort of vein, really, about talking to clinicians, what would make you pick up the phone and ask about, for example, Marfan or other conditions when you're looking at aortas and other vasculature?
Yeah, so again, I think it's about that kind of really good, thorough description of what you're seeing, because I think we can all pick up a bit of myxoid degeneration and a bit of change, but it's looking at the extent and the severity of that. And in the guideline, we mention a consensus grading system. So this was published, I think, in about 2016 now. So it's a few years old, but it's a joint Society for Cardiovascular Pathology and Association of European Cardiovascular Pathology publication, and it sets out a table essentially of the key features. So where you've got mucoid extracellular matrix accumulation, so MEMA, and where is it? Is it just between the lamellae? Is it a cutting across lamellae? Have you also got elastin breakdown? Have you also got loss of smooth muscle cell nuclei? If you've got all of those features, how widespread are those features? Are they everywhere, or are they just focal? And how severe are those features? And although I think I'm probably amongst the minority who use that grading system, it really helps me as like an aid memoir of, have I actively looked for these features? Have I really thought about how severe or otherwise they are? And if I'm getting into the moderate to severe kind of end of the spectrum, especially if it's a younger patient or somebody who hasn't got those kind of more classical risk factors of hypertension, then yeah, I would definitely be raising it as a possibility. Certainly in our autopsy specimens, they're the ones I'd be wanting to take a piece of spleen, making sure I've got DNA stored just in case something comes back later. So it's extent. It really is extent, I think, rather than any one specific feature.
Yeah, thanks very much. We talked briefly about, capacity, and one of the questions that's in is about the timescale for reporting temporal artery biopsies. We were always told to phone people, but nowadays you can never find anybody because nobody knows, because there's different people doing the biopsy as want the answer. So I know what the guidelines say about, percentages, but do you have a different, or do you have an idea or a feeling about how quickly we should be reporting these cases, particularly giant cell arteritis?
I might have to leave this one to either Lauren or Jose, just because I know that Leeds is a slightly, we're kind of a slight anomaly in that we actually have a GCA MDT, so a once a month MDT, and our rheumatologists are always available on the phone. Actually, they're pretty good. So if one of our but if they had a suspicion, then they would pick up the phone straight away. So I do know that we are slightly different, and that it's not the same, especially if you're in some of the DGHs, for example, and getting hold of a rheumatologist is not always easy. So I don't know if Lauren or Jose has a similar experience, but our clinicians are always happy to be phoned.
Sorry, so yeah, at the Brompton, we don't tend to get a lot of temporal artery biopsies, so it's difficult for me to answer that one.
And at Addenbrooke's, as you said, Kathryn, also is something that is led by the neuropathologist here, actually. But I don't think, in my experience, I don't think that they also have many issues with reaching the clinicians. But I'm not entirely sure on you know, how quick they reported those biopsies, because it's also something that goes through them.
Okay, thanks very much. Just to go back to where we started in a way, the first question was around the value of gram staining and such like on heart valves. So the question really is how frequently would you carry out gram, Grocott, other microorganism staining on cardiac valves? Which valves, why, what would be the indications?
In my experience, in my experience, we have done always when there is, for example, either macroscopic findings that could be suggestive of, you know, endocarditis, or if microscopically, we had cases before where microscopically we saw acute inflammation and then performed the bug stains just to make sure that there is no microorganisms there, even though that was not so apparent macroscopically.
Okay, thanks very much. As we're beginning to near the end of the session, one thing that I guess you mentioned working in smaller hospitals without necessarily dedicated cardiovascular pathologists. If we have a need for an external opinion, where should we send cases nowadays?
So again, I think this was one of the things that we wanted to try and highlight in the guideline, and Jose mentioned the stakeholders at the beginning. So the UK Cardiac Pathology Network is it's a network of the UK cardiac pathologists. So it's people who are working in, you know, specialist centres, transplant centres, also people who maybe do a lot of autopsy and have a specialist interest because they see a lot of cardiac pathology. There are a committee of us, so there's a kind of a smaller group of us, but that we also have at least annual meetings, and also we participate in the college autopsy webinars, for example, and some other educational meetings. So that network of people is really who to send things to. We're happy to receive whole fixed heart. So, for example, Mary Shepherd at George's, the Sheffield pathology team, the Papworth team, so Martin Goddard we mentioned earlier, they're all happy to receive fixed hearts. There are a kind of a wider group of us who will happily take slides as well and look over things. And we have a kind of, I guess, an MDT, a difficult cases type setup, where we can all circulate those cases between us as well, and say, you know, I've just not seen anything like this. So I think I'm right in saying that the website should be reasonably up to date. We do have a social media presence as well, so you can always get hold of somebody. It's Dr. Esther Yude who coordinates that network. She's in charge at the moment, but any of us within that network would always be happy to be contacted for advice about a case. And I think particularly for the autopsy cases, when you're thinking about those kind of grown-up congenital heart diseases, they're really difficult. So think about whether Kim Survana always used to say, should you be doing this case before you start? So I think having that conversation with yourself is always useful. You know, should I be the one that cuts up this heart, or is it safer for it to go into some formalin and go to somebody else? Yeah. Hopefully that helps.
Yeah, no, it's very helpful. I think the idea of knowing what you're going to do at the end of the procedure when you start is something that is quite relevant across what we do. Well, we're just about out of time, and I think we probably better call it a day for that. So thank you very much. Participants should be aware that the recording of today's webinar, including the question and answer session, will soon be available on the college website. And it's a resource then that members and fellows can use to support their implementation of the guideline. So please pass on that information to anybody who wasn't able to join us today. The other thing that we'll need to tell you is that the guidelines team will be sending you a short survey for feedback, and we'd love to hear what you have to say about the webinars so that we can make them slicker and better and more directed for your uses in future. And that just leaves me to thank Josie, Kathryn and Lauren for sharing your expertise with us today. and thank you all, the audience, for participating in the webinar. Don't forget to check the webinar page and tune in to any forthcoming webinars. The next one's on the 7th of January for a data set of cancers of unknown primary and malignancies of unknown origin. So until then, thank you very much. All the best wishes to all of you, and have a good rest of the day wherever you are. Thanks very much and goodbye.